second. Okay, great. Hello, everyone. Thank you for joining us today. It's just about 12 p.m. Eastern, so we'll go ahead and get started. A few people may join us in the following minutes, but we'll go ahead and pull the plug. Welcome, everyone, to the November COVID Info Commons Research webinar. My name is Lauren Close. I'm the Operations and Communications Manager for the Northeast Big Data Innovation Hub here at Columbia University. I'm also a leading member of the COVID Information Commons project team. The COVID Information Commons, or CIC, is a COVID-19 research collaboration platform brought to you by the Big Data Innovation Hubs and funded by the National Science Foundation's Convergence Accelerator. Every month, CIC brings together scholars from all over the country to share their research findings in the form of lightning talks. Each scholar today will also engage the community directly, answering questions about their work during a Q&A session at the end of their presentations. But before I introduce you to today's fantastic group of speakers, I'd like to first invite the Northeast Big Data Innovation Hub's Executive Director, Florence Hudson, to say a few words and tell us a bit more about the CIC.
Thank you, Lauren. Can you hear me okay?
Yes.
Great. There are lawnmowers right outside my window, so I was hoping that wasn't going to get in the way. I'm sure you've all been through this before. So good morning, good afternoon, and good evening, everybody. Thank you very much for joining us for the COVID Information Commons webinar this month. We do this every month, whether we need it or not, to bring together COVID researchers, people who are interested in what's going on with COVID research and how we tackle the pandemic today and into the future. So the COVID Information Commons was funded by the National Science Foundation's Convergence Accelerator program last year in 2020. We launched it in July of 2020. And since then, it's grown to be a community of over 1,500 people. We've had over 80 PI lightning talks, and we continue to do these every month in a way that brings together people that may not have normally spoken to each other about their COVID research, so enhances research collaboration from a multidisciplinary perspective. There are multiple tools that you could see here if you go to covidinfocommons.net, where you can look at the NSF COVID Awards and PI database, which is going to turn into a more generic COVID awards and PI database because we're adding additional NSF awards and NIH awards through the extension that we received on October 1st, our $2 million extension for the COVID Information Commons to extend the program for 4 years. So we're very excited about the growth of it. We're delighted that you're part of it. Please leverage the tools that are there. You can see there's also a COVID Research Explorer machine learning map tool that clusters the research into different categories. You can use your favorite Boolean algebra to actually customize it even further. And you can also view all the videos in our opportunities and resources. There's a video area. You can look at the PI lightning talks. Lauren does a great job of splitting them up so you can look by researcher, but we also have the entire webinar, as well as student paper challenges that we're going to be continuing into next year. So thank you very much for being part of this, and I'd like to hand it back to Lauren.
Yeah, thank you, Florence. And before we jump directly into today's discussion and start with our presentations, I also want to highlight that the COVID Info Commons is currently hiring. We at the Innovation Hub are looking for a program manager who can provide support for this type of programming that you're getting today. In addition, the program manager will work closely with our technical team to build up our existing CIC database and grow it. As Florence mentioned, we're in the process of tackling this new piece of our grant. So we encourage you to share information about this posting with anyone you think may be interested. You can find additional emails about the post at this link here, the bit.ly/CICPM program manager, or you can email us at info@covidinfocommons.net, which you can see the email address down here if you have any questions. These are our speakers today, and in addition to Florence and myself, we're also joined this afternoon by a Columbia University student, Sonia, who will be providing support on the back end and will create a summary of today's proceedings to be posted on our Hub website in the coming weeks. So thank you, Sonia, for helping us out today. And now it's my turn to introduce today's speakers. This afternoon, we'll be hearing from 4 fantastic researchers who are coming to us from all different parts of the US, ranging from Arizona to Michigan and anywhere in between. So I'd like to kick off this afternoon's webinar by introducing you to our first speaker, Professor Cherkoff of the University of Arizona. I will stop sharing my screen, and Misha, whenever you're ready, please take it away.
Thank you very much. My name is Misha Chertkov, and I'll be telling you about graphical models of pandemic. Also, I will be mentioning agent-based models. So I'm on applied math side of the aisle, and let's go on. So that's my kind of roadmap of activities which we started with pandemics basically, and what I'll be telling you about is based on those two papers which are available on arXiv, and only some portions of this roadmap is covered, and specifically I'll be talking about inference and prediction and prevention of pandemics. There are many other aspects which we are planning to go ahead, and one reason for me to talk here is maybe to look for collaborators. It's all started with data, and we got quite a lot of data on how pandemic spreads. So there are all kinds of biological, epidemiological, geographic, environment, mobility, which is very important, what we are doing, etc. Data. I don't mean to read this table literally, but I wanted to emphasize that it's important new ingredient for modelers like myself to start thinking of a new, or for that matter, start new projects to model pandemic. And on a level of modeling, we talk about very different levels of resolution. And very different sources of information, in particular from data, which I mentioned, and different expertises which are certainly needed. My position today for the purpose of this talk will be somewhere kind of in the middle, in the sense that we'll be talking about geographical maps and geographs, how we call them. I'll not be discussing very aggregated model, what we call compartmental models, even though those were very significant first step in modeling pandemic in general, not only COVID. And by the way, everything which I'll be talking about is generalizable to other pandemics, other situations, actually not only viral, but also social. So I'll be mainly discussing what we're calling graphical models, but also will be mentioning agent-based. So that's another diagram which basically put scales into the play. So we are mainly interested in these projects on a neighborhood scale, maybe a city like Tucson, or maybe county. But of course, this modeling or kind of paradigm extends to different scales. We are predicting what will happen if there is an injection of infection in a particular city, for example, through super spreader, and what will happen, projecting now what will happen 2-3 weeks from now. We of course also mean not only to predict, but also to prevent. And in the first place, I mentioned data. We want to learn parameters in our model. So all of that is under one umbrella. Very high resolution models are known under the name of agent-based models. Before pandemic started, we had quite a lot of expertise on that in the world, but very few of those, actually only one was in open source. Now you see the list of ABMs, that's how we call agent-based models, which are now all pretty much open source, and we can all play with them and extend them. They account for different effects like masking, quarantining, etc. And that's ongoing work, which is very exciting and very timely, very important. Now, we are also developing agent-based model software. We are not yet public, but we are heading towards that. And actually, well, in a day or two, we'll put a paper about that on arXiv. Features of agent-based models, they're basically working horse of epidemiology. They're resolving individual people. We are talking about city of Seattle, for example, 700,000 people. So 700 agents, 100,000 agents. So it's extremely heavy. You cannot model and you cannot prevent with this resolution. So you need to have reduced models, and that's what I'll start talking about very soon. Graphical models is one way of doing this coarse-graining model reduction. So it's macroscopic as opposed to ABMs, which were microscopic. They're supposed to be efficient, they're probabilistic. So they count, they are not answering question affirmatively, but giving you estimations of probabilities, and they're data-driven. Various inputs and various questions you can ask. In particular, what is the probability if injection of infection happen to have it spread? Here I'll put a very schematic slide, and it's actually based on a paper which is very famous, very well known, but not in epidemiology, in the computer science. And that paper which was discussing a spread of misinformation or information through internet. Imagine, so now I'm putting it in a little bit with epidemiological swing. Imagine that I have this grid, and each node in the grid represents a neighborhood. So I infected one neighborhood at moment of time 0, and red is infected. So rule of the game is that I stay infected only for one step, and then I become black. Black means removed, and otherwise, if I'm blue, I'm susceptible. So it's a probabilistic model. It basically resolves through connections possible spread, and you end up with a particular sample, which is two color, black and blue. And that's a sample, which means that there is a certain probability of this to happen, depending on initial infection. And you want to answer a question, what is the most probable configuration, or what is the probability of some particular infection? And that's, if I map to the city of Seattle, it's an illustration of how this type of model would work. So parameters now characterizing these probabilities of infection between neighbors, you need to learn, extract from data. I'm putting it all on the rack. I'm showing you how I started. Suppose I have infection here, and that's where I end up is a number of steps. So one particular step intermediate. You see that black is quite spread, but not uniformly, and that's what we want to study. So model which describes this final state happened to be a model which is known on the statistical side, or also physics side, under the name of Ising model. So it's not exactly the same. It's a graph which is a graph of this connection between different neighborhoods. So those J's represent strengths of interaction, how often people travel, and how significant travel. H is a local bias, is how much you protect it, how much you're masking, what is a policy, etc. So now you can ask questions like I mentioned before, what is the probability that infection spreads, let's say half of city of Seattle in 3 weeks after this initial infection is basically infected, initial infection injection. A lot of different questions, a lot of conclusions you can draw. You can see that you basically very often in this densely populated city goes from either everybody got infected or nobody. So there is a sharp transition, what is called in applied math physics phase transition. You depend very much on data. So data is how you calibrate your model, and you can resolve it not only in a city level. You can go to Wisconsin, for example, which is much more rural in comparison with West Coast. Again, different questions, but let me now jump to what you can do prevention-wise. You can put these graphical models in this prevention framework. And in the prevention framework, you're basically asking questions like how I can change, how I can introduce, reinforce, and if I need to enforce mandate, mask mandate, if I want to maybe limit traffic. Think about it a little bit abstractly as this polytope in a space of characteristics. And if I'm within this polytope, I'm green, I'm good. If I'm outside, I'm bad. And then I need to project myself back to this polytope. This is a type of mathematical formulation which we have for this prevention problem. So we play with that. We care about developing methodology. Methodology should be efficient. And that's what we are testing. So again, methodology, but we of course want to be practical and projected to real problems, to real, well, for example, the city of Seattle. Quite a lot of stuff, work in progress. I've been telling you a little bit about inference, didn't tell you much about learning, and overall modeling pipeline from data to high resolution and to low resolution. That's what is ahead of us. This is a team, not only from Tucson, also from San Diego, and thank you very much.
Thank you, Misha. That was great. As a reminder to all of our audience members, please remember to share your questions either in the chat or hang on to them for our moderated Q&A session at the end of the presentations. Florence will collect everyone's questions and we'll talk about them at the conclusion of today's webinar. Next, I'd like to welcome Amanda Leggett, who's coming to us from the University of Michigan. Amanda, please feel free to begin your talk.
Okay, hi and good afternoon, at least on Eastern time zone, everyone. It's my pleasure to be here today and share some of the early findings from my work on caregiving during COVID-19, specifically caregiving for an individual living with dementia during the pandemic. And I would first like to start by acknowledging my funding for this work, which comes from my Career Development Award from the National Institute on Aging and a supplement to that award specific to COVID-19. I have a fabulous research team and also mentor collaborators who have supported this work. So first, to start out about the COVID context, which I'm sure is familiar to everyone, but specific to caregiving and aging. So we know from existing work on natural disasters that older adults, especially those with pre-existing medical conditions, are at increased risk for negative effects from such global crises. And specific to COVID-19, we've seen that older age is related to critical health outcomes as well as mortality specific to COVID-19, which really puts older adults and individuals with dementia specifically and their care partners at an increased risk for negative outcomes to COVID-19. Also, throughout the pandemic, we've seen how healthcare systems have shifted to really have a singular focus on COVID, leaving fewer resources for other medical conditions, which may be very common among older adults. And so there's been a little bit more of a struggle to potentially get ordinary or routine care. So for a variety of reasons, the pandemic may be acting as a barrier to caregiving due to this ongoing fear of infection for both the caregiver and the individual with dementia for whom they're providing care. Also, we've seen changing policies during the pandemic that have impacted older adults, individuals with dementia, and their caregivers. So caregivers may be asking themselves the question, should I abide by physical distancing regulations, or do I continue to provide essential care to my friend or relative? We've seen restrictions on typical daily activities, reduced physical activity as an association of physical distancing orders, and older adults have lost many outlets, such as respite programs, or churches, or even restaurants. We don't often think about that, but just the social interaction and the chance to take a break from care that going out to eat can provide is enormous for many individuals with dementia and their caregivers. And caregivers have had a greater difficulty in accessing services and healthcare, and may have had to shift to relying on services in new modalities, such as telehealth, all of these dramatically changing the caregiving landscape. So my research has focused on primary family caregivers for an individual living with dementia during the pandemic. We've done mixed methods interviews, and today I'll be sharing some findings, some emerging findings on a preliminary sample of our participants. We have just finished wrapping up recruitment for this study. And the individuals living with dementia were community dwelling, so not in a nursing home or assisted living care facility, and they were not at the terminal stage of disease. Here's just a little bit about our sample. On average, our caregivers were in their mid-60s. The majority were married. We, being at the University of Michigan in a college town, we have a pretty highly educated sample, and you can see the diversity by race there. So starting out, how did the pandemic impact caregivers' lives, according to them? So on the left chart, you can see we asked caregivers to talk about whether the pandemic impacted their ability to participate in activities that gave them that break, that gave them respite from care. And you can see that the majority said that they did experience impact on those activities, with about half the sample saying quite a bit or extreme impact. Then on the right-hand side, at first this chart may seem encouraging, that over half of the sample said they had no financial difficulties that made caregiving more difficult. But on the flip side, you can see about half the sample did report financial difficulties, making their caregiving lives more challenging. We also asked about the impact on their relationship with the individual with dementia. And you can see, again, over half said that their relationship stress increased, both at a moderate or severe level during the pandemic. And then we asked about their ability to provide care, kind of relating to caregiving stress. Was it easier or more difficult to provide care during a pandemic? And you can see that about half of the sample said it was somewhat to extremely difficult to provide this care. We also looked at a variety of challenges and also supports that caregivers could report experiencing during the pandemic. And these were actually items that we created for the National Poll on Healthy Aging, which is sponsored by the AARP and the Michigan Medicine. And this left-hand column is that national poll sample, and we've published those findings, you can see in the upper left-hand side. So the national poll sample specifically looked at caregivers for any adult age 18 and older with any chronic illness or disability, whereas our right-hand column is our dementia caregiving sample. And you can see that universally, the dementia caregivers reported greater experiences of these caregiving challenges, such as difficulty getting medical care for one's care recipient, or providing less care to reduce risk of spread. Or you can see over half of the sample said they received less support from family and friends in assisting with care during the pandemic. I want to hone in a little bit on these top two challenges of getting needed and home and out of home services and in getting needed medical care. So specifically, we asked caregivers what sorts of services they had greater difficulty in accessing. And again, similarly there, you can see that about half of the sample said they had greater difficulty getting respite from family or friends. And you can see nearly half of our sample said they had difficulty getting regular medical care, such as physician appointments, with day activity programs also almost nearing half of our sample. Because this was a mixed method study, we also did in-depth interviews with the caregivers, and these issues of medical care and community-based services came up again and again. So I thought I would quickly share with you some striking quotes that we've seen from these interviews. So first here, the difficulty of just getting a medical appointment during the pandemic. You can see the caregiver said they had to reschedule or cancel an appointment because the individual with dementia didn't want to go, and this can be a common challenge with dementia. And then the caregiver said it was very difficult to then get another appointment because the wait times were so long, and the caregiver really had to advocate for that appointment. A complementary issue is that often caregivers were not allowed in appointments during the pandemic, with only the patient being allowed in. But when it comes to dementia, this is very difficult because they may not be able to relay an adequate history or adequately describe the symptoms or what they're experiencing. And so you can see this caregiver saying they weren't allowed back at first, which was a problem. And they felt embarrassed somewhat to try and have to explain to the care provider why they needed to be back there, because they didn't want the individual with dementia to feel ashamed. They also talked about difficulty getting respite services in the community and to their home, having long wait times, or people being scheduled to come who would just never show up. And then, of course, telehealth, which has become a new thing for many of us throughout the pandemic. Caregivers had really mixed experiences with that, some citing great benefit of not having to leave the home for appointments, but you can see with this caregiver here saying, some were helpful and some were a total waste of time, that they felt the doctor really needed to see the individual with dementia in person. And then finally, just getting comfortable in managing the technology to have telehealth appointments was a new challenge, especially for older adults and individuals with dementia. Here you see the caregiver describing that the gentleman on the phone was trying to help the individual with dementia get set up for that telehealth appointment, and just really, belittling the individual with dementia for not knowing how to use a computer. And so the individual with dementia ended up feeling ashamed. So in conclusion, there's, I think, many implications here, but older adults living with dementia are very complex patients. They have multiple comorbidities. Often that makes their care management very challenging, particularly in a pandemic context. And so when handling care, I think one of the recommendations I would put forth is that health systems really need to consider the role of caregivers in patient healthcare, and making sure that they have plans for how they can safely involve caregivers in these appointments and in future care planning. So thank you so much for attending today. And of course, much gratitude to my participants who gave of their time during a crazy pandemic to share their stories with me. Thank you.
Thank you so much, Amanda. Really appreciate you taking the time to tell us a bit more about your most current research. Next, I'd like to introduce Ashley Landrum, who's coming to us today from Texas Tech University. Ashley, please feel free to take it away.
All right, thank you so much. Sorry, I had to unmute my microphone there for a second. So we are so glad to be invited to these talks today. And I'm going to talk briefly about the NSF funded project that I have in collaboration with KQED Public Media from San Francisco, called Influencing Young Adults, Science Engagement and Learning with COVID-19 Media Coverage. So this is our really just part of our project team. And you can see we have members from both KQED and my group over at Texas Tech, and then Scott Berg at Rockman et al. Is serving as our external evaluator. So we had several project aims, the first of which was to build a better understanding of young adult audiences for science media, to provide information about future and missing audiences for this type of content, to build audience research opportunities for professional content creators, such as those in the news team at KQED, and build an academic practitioner collaboration. And this was part of a larger grant that we had funded through the NSF pre-pandemic. And then to support the production of science content, specifically that surrounding COVID-19. So we had two primary research questions. And the first was, well, how could COVID-19 coverage be designed to best inform, engage, and educate millennials and younger adult audiences about the science of virus transmission and prevention? And we had several studies on this, and I'll just briefly go over those. And then the second part of this, and this is the part that was led by Scott from Rockman, was, can we develop best practices for crisis reporting as journalists respond to both constantly updating information and changing audience needs? And then how can these be used by other media outlets? And this was our process evaluation. So because we're limited on time, please do look for our QR codes. And again, this will be available in the recording as well. These will link you to the full study report for each of the studies that I present. And on the final page, it'll link you to our website. So the first study that we looked at was how misinformation is disseminated on Twitter about the pandemic. And the sheer number of conversations disseminating misinformation about the virus in 2020 was very disheartening, but not particularly surprising. So we had examined the misinformation being shared online, really to kind of focus in on what those knowledge gaps were from the public. And we came to realize that news organizations really do need to create content that is informative, accurate, and timely, so that when people get online to, quote, do their own research, there is information that's accurate and available there in order to help fill these knowledge gaps in our communities about the virus. And this emphasizes the importance, of doing research on knowledge gaps, specifically like those related to COVID-19. Our second set of studies that we worked on were focusing around the idea of communicating consensus versus helping audiences better understand information by explaining kind of what's going on. So we all saw during the pandemic, Dr. Fauci or others getting up and saying, this is what the science says, this is what the science believes. But what we found was that presenting participants with a consensus message saying that science knows this, that there's scientific consensus that, for example, masks prevents the transmission of COVID-19. This does not significantly influence their beliefs, but the presence of an infographic depicting how masks help to spread COVID-19 did in some circumstances influence participants' beliefs. And for this, we used the image that was published in Science, but we had edited it a little bit to be more friendly to general audiences, where we showed, somebody's infected but not showing symptoms, wearing a mask versus not wearing a mask. And then when they're wearing a mask, you can really kind of intuitively understand from the image how you'd be less likely to both transmit and take in viral particles. And of course, because of the nature of the polarization around COVID-19, we did find that political party was the strongest predictor of participants' beliefs about COVID-19 risks, mask wearing, and policy support for masks. But to the benefit, the infographic, this here did seem to influence Republicans and male participants' beliefs about mask wearing, which is really important because those are the audiences that seem to reject the information most. We also had a survey about germ and vaccine attitudes and knowledge, and where we tested people's interests or beliefs, for example, in or whether they anthropomorphize germs and viruses. So germs move to places that make it easier for people to infect them, which of course is false, but 60% of people got that incorrect. So this shows you people's understanding is still a bit, oops, did not mean to do that, going backwards. Participants' understanding is still a little bit weak. In addition, understanding whether diseases are caused by viruses or bacteria is a little weak. We found that although the correct answer for what causes strep throat is bacteria, only 31% of participants in a national sample got that correct. COVID-19, 60% understood that virus was the correct answer. It is, the V stands for virus after all, so that I think getting that information pretty consistently, but it's still surprising that 40% of people who responded to this said bacteria. We also looked at the myths and rumors, such as COVID-19 can be transmitted via 5G mobile phone signals. Most people understood that that was incorrect. So only 10% really thought that. Only 21% thought COVID-19 can be killed by warm water. And only 15% thought that COVID-19 is less dangerous than the flu. So most people seem to be on the right page here. Where you start to see the effects of political polarization, for example, is in the belief that hydroxychloroquine has been scientifically proven to be effective in treating COVID-19. You see a bit more of a split there. Or the belief that COVID-19 was created as a weapon in a Chinese lab, 42% believe that. So you can still see the misinformation spreading. Also, we measured vaccine intentions. And again, we did collect this data during the limited availability of vaccines. So this was January to February in 2021. And at this point, 5% were vaccinated already, but 63% they were likely to get vaccinated, and 32% said unlikely. And this is pretty consistent with what we see for who's vaccinated now, or the number of people vaccinated now. And you can see that this varies pretty strongly by political ideology. Only 16% of people who identify as politically liberal said it was unlikely that they would get a vaccine, whereas 40% of those who identify as politically conservative said it was unlikely. Finally, I just want to briefly talk about our academic practitioner collaboration. So this was one of the largest public investments in science and media communication research collaborations. Our process evaluation was conducted by, again, Scott Berg, to assess the impact of our two groups sort of working together, and he had embedded himself in our team. We did have many accomplishments despite some unforeseen challenges. Really, the two different timelines that journalists versus academics tend to work on was definitely something that we found to be a difficult hurdle to overcome. But it did help create a mutual respect and appreciation for each other's skills and knowledge and working methods. We got to apply both applied and basic research. This whole process together validated each team's the ways that they've come to gain knowledge and our abilities. Also, my team, for example, particularly the PhD students, really benefited from having the opportunity to talk to professionals and find out what the greatest needs are in research for journalism and science communication in general. But KQED also came to understand sort of how we go about our research, and some of the quotes from the news journalists had expressed how it's really changed the way that they see when they're reporting how science is done, understanding science. And so we hope that this is a process that can be replicated. So thank you so much. If you want to hear more about our studies, you can go to our website. And again, this QR code will link you there. And here's my email address if you have any questions. Thank you.
Thank you, Ashley. It's really helpful. It's interesting to see this intersection between media and science. So I'm sure we'll get lots of questions about this from the audience. And as a reminder to our fantastic audience, if you have any questions for any of our speakers, either hang on to them for the moderated Q&A session at the end, or go ahead and drop them in the chat, and we'll see if our speakers have any thoughts in between now and when we open it up to all of you. So I'd like to introduce our final speaker for today, Elena Solo-Gabriel, who's based in the University of Miami. Helena, we're leaving it to you. Please take it away.
Okay, thank you. Can you see my screen? Okay. Thanks to the moderators. Thank you so much for hosting this event. I'm here to speak about our group research called South Florida RAD. It's focused on a wastewater-based monitoring program for COVID-19. Our project is a joint project between University of Miami and Weill Cornell Medicine. We are funded through NIH. There are 3 PIs on the project, Chris Mason of Weill Cornell Medicine, and from the University of Miami, Stephan Scher and myself. I am Helena Solo-Gabriel. And for more information about our project, you can visit covidsfrad.org. I wanted to begin by describing the goals of our project. We have 3 specific aims. They focus on data standardization in developing an informatics infrastructure, characterizing the wastewater, and then integrating that information with human health surveillance. So essentially, we are pairing or coupling human information, human COVID-19 cases with wastewater information. We're integrating that in a data platform that then we use to develop models to predict outbreaks. Our intent is that these models will be used by decision makers to develop policies that will minimize the transmission of disease. A big portion of our research is in data standardization. We're working with 3 laboratories, and integrating all of the information from all the laboratories coupled with the human health surveillance is a challenge. And a lot of our work is focused on developing that data platform. But in this talk, I'm going to present mostly on the outbreak characterization portion of the work. So our ultimate objective is to relate wastewater measurements to predict COVID-19 cases. This involves pairing the human health surveillance with wastewater SARS-CoV-2 levels. As we know, in addition to transmission through aerosolized droplets from respiratory systems, humans that are ill with COVID-19 will also excrete the virus through their feces and urine. And as a result, it is found in the sanitary sewer system. We can then collect the sample from the sanitary sewer system and then analyze it for the RNA of the virus called SARS-CoV-2. In order to do this work, every one of our sample collection plans are paired, again, with a human surveillance system. We have a student residential monitoring program that is led through our University of Miami, which has a very extensive testing, tracking, and tracing system led by our provost for research and also the president of the university, who are experts in public health. And on campus, our main academic campus is the Gables campus, and you can see our monitoring stations given by the blue balloons there. In terms of student surveillance, during the fall and spring of 21, the students were tested weekly by nasal swab qPCR augmented with breath tests. And then we were able to get those results by total test and by positive patients, but on the level of both the building and building scale. In addition, during the fall and summer of 21, students that were unvaccinated were tested weekly. And then when we got a spike at one of the dorms, the sewage from the dorms, all the residential students were tested at that time, providing us with additional information about the occurrence of COVID-19 within the building. In addition to our student residential monitoring, we also have the university hospital that treats known numbers of COVID patients, and we have access to electronic medical records that provide us with information about the severity of the disease of the patients within the hospital, and we couple that with the wastewater data. And then at the county level, we also have samples that we collect from a major wastewater treatment plant called the Central District Wastewater Treatment Plant, which services about 800,000 people in Miami-Dade County. And we pair that up with the data that's available on the county basis through the Department of Health. One of the main innovations that we have developed through our study is a new technology for measuring SARS-CoV-2 in wastewater. We call it the Volcano Second Generation, or V2G qPCR. This technology was developed through the University of Miami Center for AIDS Research, CFAR, under the direction of Dr. Mark Sharkey. Mark Sharkey was developing sample methods or analysis methods for saliva. And as you can see in the upper right graphic, the negative versus the positive results are very distinct in terms of their fluorescence. This technology uses a novel polymerase that is capable of using either DNA and RNA, and therefore avoids a cDNA synthesis step, simplifying the process, making the process less expensive and also faster. We have a turnaround time once it gets to Mark Sharkey's lab of about 2.5 hours. This technology was adjusted for measurements in wastewater. And as you can see, comparison with the more traditional ARC-T-qPCR versus the V2G qPCR provides comparable results between the two technologies. In terms of our university surveillance, this is the documentation of student and faculty positives at the University of Miami over time as given by our dashboard. On the left, we have the number of people testing positive. The gray bars correspond to the students and the gold correspond to faculty and staff. On the right, we can put the wastewater levels in a logarithmic scale where wastewater is expressed in genomic copies per liter. We have our detection limit for our SARS-CoV-2, which is on the order of about 100 genomic copies per liter. And then superimposing on that, we have our weekly wastewater data given by the yellow squares as shown here. And then we can start taking moving averages of the human health 7-day moving average and a 3 sample moving average for the wastewater. And what we can see from our on-campus surveillance is early during the fall semester, there was a wave that was observed before we collected our wastewater samples. Then there was a second wave during the fall semester that was captured by the wastewater. There was a larger wave during the January time period, again, which was captured by the wastewater. And then the fourth wave during the spring semester, observed both in the wastewater and in the human cases. Interestingly, once the vaccine was available for the community and the students, the values in the wastewater and also amongst the human population decreased significantly. And then we had the last wave, the fifth wave, associated towards the end of the summer, associated with the Delta variant. This data was analyzed by epidemiologists on our project, Naresh Kumar and Alejandro Montero. They found through this analysis that SARS-CoV-2 in wastewater was a 4-day lead indicator of cases on campus. They developed a model based on the wastewater data where the concentration of RNA, genomic copies per liter given by the C, take the natural logarithm of that, will give us a relationship, an estimate of the positivity. So for example, if we have 10 to the 6 or 1 million genomic copies per liter in the sewage, we can estimate that the individuals that are contributing to that sewage have about there's a 12% positivity, 12% of the population is likely positive within that group. This is our weekly sampling program. And in addition to weekly, right now, actually, we're sampling twice a week. But in addition to our weekly sampling, we also have hourly and daily sampling that we also do to answer specific questions. But our sampling is pretty similar in terms of how we process them, but the way we process our sample is we take our raw wastewater and we concentrate it using electronegative filtration. We produce 3 filters, and each of those filters are then sent to one of the 3 laboratories, either Mark Sharkey's lab at Center for AIDS Research, Sean Williams Laboratory at the Oncogenomics Shared Resource at the Sylvester Comprehensive Cancer Center at the University of Miami, or Chris Mason's lab at the Integrated Genomics Laboratory at Weill Cornell Medicine. 2 of those filters undergo rapid detection by both V2G with checking by RT-qPCR, and that is what we use on a weekly basis for real-time forecasting of COVID cases on campus. Additional filters also go to Chris Mason, plus at Sean Williams Lab. Those filters also undergo a deep sequencing process using ARTIC. And in Chris Mason's lab, that data is then processed through a bioinformatic pipeline that then gives information about variants. In terms of the results, the top results here are the qPCR by V2G, giving us the values over time. And then on the bottom graph, we have the variation of the variants. As you can see, these are the dates of the sample collection on the bottom. And we can see from the March to early June timeframe, the dominance of the variants within the wastewater was the alpha and beta variants. But as we proceed into June through July, and then ultimately into August and September, we get a dominance of the Delta variant as observed in the wastewater. And this was reflected within the patient samples as well, such that the wastewater is able to also not only detect the COVID-19 cases, but also can provide information about the variants among the community. So this is a presentation of some of the work that we're doing. Before I end, I wanted to again acknowledge the National Institutes of Health for the provision of funding, also the collaboration through the University of Miami and Weill Cornell Medicine. This collaboration would not have been possible without the support that we received through the university, through the upper leadership, through facilities, through environmental health and safety, our laboratory teams, students, and field sampling teams. Very much appreciated. And I will end by providing my email address and then also our webpage for more information at covidsfrad.org. Thank you.
Thank you, Helena. That was really fantastic. And I want to end this presentation and all the presentation sessions by thanking each of our researchers who've shared such great work with us today. Each of your presentations provided very unique insights into the latest COVID-19 research, and we really appreciate your contributions in talking to us about all of your work today. For the audience, let me say that each of our speakers' presentations will also be made available on our website, covidinfocommons.net, and on our YouTube channel later this week. So if you want to go back, you missed any details, you're free to do that on your own time. And before we segue into today's Q&A session, I'm going to briefly share the below information with you as an audience. We encourage you to take advantage of the numerous avenues that you can stay in touch with the COVID Info Commons and the Northeast Big Data Innovation Hub. You can check out our website, subscribe to our newsletter, follow us on social media. We're on Twitter, Instagram, Slack, LinkedIn. If you have any questions or suggestions about our events, you can always email us at info@covidinfocommons.net. I will drop all of this information from the slide directly into the chat, so please go through these communication options at your own pace. We love hearing from the community, and we really encourage you to reach out. Finally, I'll mention that when we eventually close out the Zoom webinar for today, you will receive a little pop-up notice in Zoom asking you to complete a survey about this event. We really hope you'll consider giving us your feedback. We're always trying to improve, and we welcome all of your insights. And I would also encourage each of you to sign up for our mailing list if you haven't already done so. We're in the process of organizing our 2022 events roster, and we'll be sharing more information about those events with our community shortly. So again, I will drop all the information about each of these communication platforms into the chat. So now I'd like to open it up to Q&A from the audience. Several of you have already posted great questions in the chat box. Thank you for that. But we'll also give you an option to speak directly to our presenters here today. And I'm going to hand it over to Florence to kick off our Q&A conversation with some of her own questions for our speakers.
Excellent. Thank you so much, Lauren. Can you hear me? I'm
Yes,
having
we
fun with
can.
my little earbuds today. Okay, thank you so much. Well, those were excellent as always. And I know Miranda joined us again today and always says it's great the range of research we get to hear. You know, you get to hear from people that you may not always collaborate with, and it's very enlightening. And sometimes that allows you to think of what you can do together. So what I'd like to do is, Giannis and Ashley had a great discussion going on in the chat, but I think there were a couple of pieces that maybe we didn't get answers to yet. And I think Ashley, I know you have some friends with you today that might be able to help answer some of them, as you mentioned. So the two questions that I see that I don't know were answered yet is how much misinformation could you trace back to official, quote unquote, or credible, quote unquote, scientific sources? And that actually might be a variable. And is it possible to make a timeline with the misinformation, the source, and when did science debunk or refute that myth or misinformation, which the issues termed as misinformation are still open questions? Very provocative question, I mean. So Ashley, do you have any comments?
Yeah, so we had sort of two studies, I think, that touched on misinformation, and I can let Sevda speak a bit to the first, which was a collection of what we referred to as misinformation chatter that occurred on Twitter. The other part was the survey study that I had run, where we looked at people's knowledge and beliefs about germs, vaccines, and COVID-19. Now, we recognize that some aspects of, now I should say first, we didn't phrase any of the items to participants as misinformation. We said, here are things that people say or believe. To what extent do you think they're likely to be true? And they could pick between, definitely false, likely true, or definitely true. So in a way, we weren't necessarily taking a stance, particularly with regard to the COVID items. The germ items, we have, clear evidence, for example, that germs, which colloquially is referring to bacteria and viruses, are not sentient and they don't have agency. So for those items, we don't have like a specific article that says, well, here's what you believe about, germs being able to find you. But I think like a lot of that comes from things like the 10-second rule, right? People believe, oh, you can drop some food, and if you grab it before the germs can rush and come get it, then you're fine. But again, for the COVID-19 items, the ones that we used, we actually do have information or articles that were posted on the CDC's website or the WHO that refute certain claims. But again, even ones like the idea about whether or not COVID-19 was created as a bioweapon, I mean, can you really know for sure? The CDC and others say it's highly unlikely that it was done this way. And then if you look at the chatter amongst those who study viral transmission and viral evolution on Twitter, my husband is sort of exists a little bit in that area, not in virus transmission, but in the evolution cycle. So he kind of showed me where to look. You see that they are also talking about how it's not likely to be true. But again, important for our study is that we didn't say whether it was or was not true. We were mostly pointing out that the different people believed those things differently depending on what sources of information they're likely to access. And so that comes back to ideas in psychology and in communication about sort of confirmation bias and selective source seeking, selection bias. So that's how we got those. So those specific items that we use, we do have things for, but we also recognize that there's a lot of information out there that does exist in this sort of in-between state. And we should caution people not to be too quick to immediately slap something with the label misinformation when it's possible that and that's another reason why we had used, for example, for the hydroxychloroquine item, we said that it had been scientifically proven, not that people thought it was effective or ineffective. At that point, it had not been scientifically proven, regardless of some people's sort of experiences with it. So we were sort of careful with that. And yes, as Miranda says, the public can be quite uncomfortable with the idea that science is a process and deals with a lot of uncertainty, 100%. And I think they equate that sometimes with political speech, and any of that mitigating is seen as trying to hide something. And so that's really frustrating. Yeah, okay, so Yana said, I don't think you're proving confirmation bias, rather that Republicans are more skeptical than Democrats. I would disagree with that because in all of the research that we've done, where we've introduced information into a system, if it is consistent with people's beliefs, they will accept it. And if it is not consistent with their beliefs, they will reject it. And that is it. Republicans don't show any more or less skepticism than Democrats do. And Democrats don't show any more or less bias towards or supporting science than Republicans do. It's completely issue dependent. And there's decades of research that shows that.
This is such an interesting discussion. When I, even talk to family members, we'll go to a family event, and I talk to the host, oh, you vaccinated? He goes, maybe I am, maybe I'm not. I'm like, okay, glad we all came, but, I think, what is it about the human that decides if they believe in it or not? I mean, if there were no political parties, would they still feel that way?
So we talk about
what is it?
Yeah, it's so in some ways people will refer to it as being irrational, but it's really not an irrational process. It's based on people's experience comparing new information to what their prior experience has been, or filtering it through their core identity. So if it seems like it could be true, then it's easier to accept. The same way as if you ask a parent, or you tell a parent, oh, I saw your child smoking. They're like, not my child, that's not possible. It doesn't jive with what I know, or what I've experienced. And different people might, experience those things differently, or have a different set of prior experiences, prior attitudes, prior beliefs that sort of filter the way that you see information. And to this idea of skepticism, we had a study where we used the Zika virus. And we talked about how it could cause microcephaly. And in one condition, we paired it in a journalistic column with climate change and said, well, if you're concerned about Zika, you should be concerned about climate change, because as the earth gets warmer and more habitable to the Aedes aegypti mosquito, we're going to see Zika happen in places where it wouldn't have been able to occur before. And then we had another condition said, oh, if you're concerned about Zika, you should be concerned about immigration, because as people come from areas of the world where the Aedes aegypti mosquito is much more common, because the nature of this disease is to be not just mosquito-borne, but also blood-borne, and transmittable that way, then you should be concerned about that. In the condition in which we had climate change, had Zika tied to climate change, Republicans completely denied that Zika was a thing and that they should be concerned about it and that it caused microcephaly. In the condition where we tied it to immigration, Democrats were completely rejecting the science of Zika and said it was not a thing and that we shouldn't have to be concerned about it, and that it doesn't cause microcephaly. So you can get anybody to reject information if you tie it up with information that is inconsistent with their ideology. Right now, political ideology seems to be kind of a core ideology. Even religion is being tied up with different political groups. But people can have other core ideologies, and when information conflicts with those, they may be just as more likely to reject it.
Yeah, I feel like, it's the 5 whys, like why, like we have to keep asking that until we get all the way down, to like the little atom, that.
Well, and
so
often people don't necessarily know, and they don't necessarily know that they're sort of justifying after the fact as to why they reject or support something. And we also have work on the HPV vaccine and shown that there was like 0 resistance to the Hep C vaccine. And it's the same thing, right? It's a sexually transmitted disease that can cause cancer. And so, but everybody's went and got their vaccine. When you're 12 or 13, it's not a big deal. But anytime something gets a little bit of press and then it starts being, promulgated in the news cycles, and then it gets tied up with either political ideology or political funding, and then you start to see resistance against it. And so with COVID-19, honestly, and this is a hypothesis, but I would project that had Donald Trump won the election for 2020 and still been president, we would not see a negative reaction toward the vaccine, because we would have seen a lot more messaging that Donald Trump and the Republican Party were responsible for getting the vaccine out quickly, and Operation Warp Speed, and then you should get it. And we might actually see skepticism among political liberals not wanting to get something that they thought Donald Trump had his hand in. So I really think that there's a lot of we're always very ready to call members of an opposite political party or a different ideology, even among the left, people who are really far left, talking about people who are maybe less progressive, and people on the really far right, referring to some as rhinos. We're always ready to tell each other that they're less rational thinkers, or we're more skeptical, or we're more scientifically minded. But really, this is just the basis of human thought. And we're not particularly we're very good at being skeptical about when stuff disagrees with our worldview, but we're really bad at being skeptical when it's consistent with it.
Very interesting. So I think this may have taken some people by surprise, this whole political element regarding vaccinations. I don't think that was a thing way back when, when you had to get measles, mumps, rubella. I don't think it was politically, divisive, but it would be interesting to look and see, when does this all start, and will it persist, or is there a way to neutralize it for the future? God forbid, and probabilistically, when we have another one that we need to try to tackle from a pandemic perspective. So thank you for sticking up for what you know and making clear what we know and what we don't know, and for this great discussion. I actually have another question for Ashley, and then I want to go to one for Helena. And so, Ashley, one of the things I was thinking when you were presenting is, did you test the infographic by age group? I know you were talking about men, and I think I know you started out talking about how your students are younger people. So did you test any of that by age group, and were there different responses based on that?
We don't have, we have that data, but I haven't looked at it.
Okay. That might be
it's possible
interesting
for me
too.
to look at that.
Yeah, well, we're not making you. This isn't homework. You don't have to come back. But if you did figure it out, want to come back in the future and tell us, well, we found new insights, that might be interesting, because a lot of us are trying to engage, the students, because they're the future. They're going to be leading the planet before long, right, when we age out. So it is important to see how they react to things and to help us as we move forward. So it was very insightful. Great. Oh, and Miranda just posted a recent Smithsonian article on history of vaccine resistance. Oh, I can't wait to read it. Thank you. Actually, Lauren and I were just talking about how there's so much rich content in the chat. We have to make sure that we bring that. We had to figure out where we're going to put it on the KIC website, but we're going to start curating this and bringing it in. So thank you for putting all your cool stuff in there. And then Helena, I had a question for you. I was looking at, your colorful chart on the bottom with all the Delta variants on the right. And it made me think, are some of the variants easier to detect in wastewater?
The variants have their challenges in terms of how to detect them and how to measure them. I am not a molecular scientist. I'm more on the front end and collecting the samples and then bringing it over to the molecular scientists. But I am fascinated and amazed that the molecular scientists are capable of taking a very dirty sample, which is wastewater, and being able to purify it to the point that they can get clean RNA. Not only do they know that it's SARS-CoV-2, but they know they can track all the mutations along the length of the genetic code. And then based on where those mutations happen, and it's not just in one place. The Delta is defined by multiple mutations. And so then from that, they fingerprint it and know that it's Delta. So yes, it can be done, and it's pretty amazing that they can do that. It can be done. About a decade ago, I don't think we were capable of doing this. The science has really moved and progressed very quickly.
So much. I think of biomarkers. Nobody talked about those 15 years ago. Now people talk about their biomarkers all the time, and there's so much more information we can get now from stuff we had, but now we can just analyze it better and we can find more things. Okay, very interesting. Are there any other questions? Oh, I had one quick question. So what happened with the other variants? So are they still out there lurking since you have so much Delta in there?
It's my understanding that Delta has overwhelmed everything. It sort of took over as a virus, as a variant of the virus. And so it's pretty much all Delta in patients and also in what we see in our wastewater.
Yeah, I'm just wondering, if they're lurking and then Delta gets tired, surprise, Gamma's back or something. So it's just interesting to watch the evolution of this. And I I think when we go through something like this, it's the things we don't know that are really, that we really want to try to figure out. And that's so hard to know because you don't know that you don't know it. So asking all these questions around it, I think is really important. And it's great that you have all this cool research. Thank you for sharing it.
Thank you. And it's amazing to see that it actually started and then sort of spread and sort of dominated. And I don't think anybody really expected it from the very beginning. But now that it's happened, I think people say, oh yeah, it makes sense. So thank you.
Yes, absolutely. So Giannis, I didn't remember that Biden said he wouldn't vaccinate himself with a vaccine that was produced during the Trump administration. Did he really say that?
Yep. Yeah, he did, and it was played by his political opponents. Now, I mean, he said it. I mean, that confirms, I think, what Ashley was saying, that he was doing it for political reasons or because it was the political campaign. So he was trying to be like anti-Trump administration. So. But that acts as a boomerang, and the same thing, the debacle with the masks, for example, which Fauci was involved. That also, like anytime there is a scientific debacle in the front stage, that increases the resistance, the doubts, and all that stuff. I mean, but scientists naturally argue. That's, I think. And naturally are skeptics. So I think the attempt to vilify skepticism is what makes people even more skeptic. Instead of embracing it and say, yes, we don't know, but for fear, because we don't know, we should err on the side of caution. That would be a more credible message to give to people than actually to vilify the skepticism, which actually is very, very healthy.
Yeah.
That's my take.
Yeah, and everyone gets their own opinion. That's the joy of having your own life, right? I know I have a family member that doesn't want to have her young boys vaccinated because she's afraid that, they lose their fertility. And so I look at it and say, well, you want them to live long enough to find out if they have that problem, so because we know people who've died from it. So, but, everyone has to make their own choices, but it's very interesting. I think going forward, the political and social sciences related to pandemics just has to be studied a lot more. And we have to be open to the information we get and the insights we get that don't make sense to us. Because I think that's how some of us feel, like that doesn't make any sense. Why do you feel that way? But they do feel that way, or they think that way. And we have to be very open to accepting it and then figuring out what that means. So this is very, very valuable discussion. Thank you, everybody. Okay, did you want to ask your question out loud, Giannis?
You mean the last one I put in the chat?
Yeah, the one that I did. I think you just put that in. Yeah.
Yeah, that's. I was wondering, like, if the researchers have identified by how many atoms, or even it could be like by how many bases, the nucleotide bases, do the variants differ from each other? I mean, not just the delta, but because the delta is the most prevalent, I would be curious to know that answer, which is kind of like a very like trivia type of answer that you can ask like in a high school or in a college level, but I would be curious, and that has never been mentioned in. I try to attend as many seminars. So if anybody knows the answer, please email me, because as a point of trivia, I would like to know that.
And it's not so trivial. So,
Michael, I don't know the exact answer, but I know it's a handful. They look at a handful of, a handful of base pairs where they may be mismatched.
I'll jump in a little bit here. Actually, defining the variants is somewhat difficult to do, because sort of how much difference does there have to be to actually qualify as being labeled a new variant? And there are people who are tasked with kind of making these decisions, but usually after something has been pretty widely circulated, they kind of hone in on the exact base changes and amino acid changes that are needed to kind of qualify as being that variant. But I don't think there's sort of one single, I think it's sort of like a small suite of changes that define, say, a Delta, and then there's different flavors of the variants themselves. So it's a tougher question, and than I think people realize. This is why I'm not a virologist.
Oh, well, there's always time. You can become a virologist. So, Lauren, what they're making me think is, what you wanted to do with one of our other newsletters for the National Student Data Corps, where you put questions in the newsletter and then ask for experts to answer it. I wonder if that would be interesting to do with the KIC newsletter, because we do a newsletter every month to usually announce the next event. We're going to take December off for the holidays, so we'll start up again in the new year. But when we do the newsletter, we could potentially put one of these questions in and ask for people to respond, like send them to the Slack channel, make it a maybe make it an item in the Slack channel or something. That might be fun.
It's an interesting idea. Sure, we'll have to play around with it.
Yeah, play around with it. She always does it better than I come up with the weird ideas, so that's good.
I didn't mean it like that, but
no, it's okay. I know. I'm an innovator. I'm used to it. Okay, very good. Are there any other, I think, Misha, you had one more comment you just put in here for Ashley. Ashley, did you see that? Your last
one
point?
from Michael or Misha?
From Michael. Yeah, Michael, Misha.
The same, yeah. I can clarify, yeah.
Yeah. Well, okay. So this is an interesting point. So rarely people's response to info is skeptical if it does not contribute to their views, but is it different if we replace general public with scientists? Well, so this is interesting. I think, at least anecdotally, many of us can think of situations in which scientists who work in each of our areas are readily promoting research that done by others that supports their hypothesis of choice, but then become sort of, in some cases, like overly skeptical to the point where they're no longer thinking scientifically if information contradicts their theory of choice. And a great example of this is actually within the research on scientific consensus messaging in communication research. There are huge divisions about this. If you submit for publication a study that does not support that scientific consensus messaging works for converting general public's views, then there's at least 2 authors that you will get angry emails from telling you why all of your research is wrong. So I think while scientists might be trained to be better at this, even if you are trained to think scientifically as a person, you are still very it is still very possible for you to end up doing this. In fact, there's researchers who are convinced that their theoretical ideas should work, and when they don't work the way they're supposed to, they manufacture data and they end up with their research being retracted, and maybe less frequent. But again, it is very possible for scientists to do the same thing.
Absolutely. And then we were just asked, following to Misha's question, is there similar data about how health workers are accepting this data?
Yeah, so health workers, again, are, while they may work so you have a variety of different disciplines within sort of health work or medical professionals in general. And you have to think that many of them don't necessarily carry the expertise in virology that would sort of be a stronger anchor for having people accept either how vaccines work, or how the virus is transmitted, or how dangerous a Delta variant is versus other versions. So you still will see a lot of variability among health workers. And this is particularly true. You'll see misinformation being created or spread by people who identify as nurses or as medical aides, or in some cases, even doctors. But again, even from our research, we show that there are a lot of doctors who don't believe in evolution, and there are a lot of engineers who believe the Earth is flat. So just because you have expertise, and I shouldn't say, let me rephrase, it's not that a lot of engineers believe the Earth is flat. When you talk to flat earthers, those with higher education, because there are a chunk, about 20% that have higher education of flat earthers, they often are engineers and medical doctors. So this is not to attack engineers and medical doctors, but just to point out that your core ideology may or may not be attached to what kind of job or career or knowledge that you have. And there are still ways for you to sort of justify whatever your belief system is.
Sure, it was following on being surprised of the low vaccination rate among health workers, and then the question was going to are they because they feel that they understand more science and hence are in a position to be negative, or they believe less, and is there any difference of opinions compared to general population? Is a possible explanation is, will health worker argues that because he or she are working with science or working with doctors on a common base, then they are in a more of a position to negate or to disagree with.
Yeah, and I think that's troubling, right? Because the assumption is that if somebody has any sort of health background, if they're working inside of hospitals, that gives them some level of expertise, and so they seem like they might have more insight, but that really is not necessarily the case, and they very well could be acting from a political or religious or cultural group stance that is different from what, so here in Lubbock, Texas, for example, it's a very, very politically conservative area. There are 1,000 workers at the university medical system that are refusing to get vaccinated, who are going to lose their job in the next week if they don't. And there's a lot of messaging about how that's unfair. They were the saviors of the city of Lubbock, in battling COVID. Why should they be forced to be vaccinated? And so you ask, well, why? But you say, well, that's 1,000, but then there's like 80,000 who are vaccinated. So, so what is different about this small group compared to the rest of it, right? Or you look at the doctor who published the paper on MMR vaccine and a correlation to autism, that it was retracted. The data was fraudulent for a whole bunch of different reasons, but yet because he had a medical degree, people assume that he had some insight. But, again, you can always find one person, and this is where sort of the philosophy of scientific consensus is what becomes most important, right? It's not one-off person who happens to have a title, but is what is the community as a whole. But unfortunately, then when you start talking about the skeptical community or the conspiracy community, consensus can also be seen as collusion. So it is very difficult to try to find ways to communicate effectively.
Very interesting. And Misha, you raised your hand?
Yeah, so follow up on the discussion, which is fascinating. Scientific versus general public consensus or not. I can think about kind of reverse. One other subject which I'm interested in is AI versus, how public and how scientists use or accept or not. And here we have a kind of reverse. So public accepted because we have all those gadgets and they work fantastically, by scientists in their scientific methods often use it much less and very resistive because of a tradition and all of that. So any sociology input on that?
Very interesting on the acceptance of AI.
I brought it as a reverse situation when public is much easier to accept than researchers. So do you see in the context of this spread of, it's a question to Ashley, in the context of spread of misinformation, kind of opposite effect?
We haven't actually gone into separate populations and interviewed them specifically. We have just the national representative data from the US. So I couldn't answer that specifically, but it would definitely be something interesting to look at.
Yes, and if I could add to that, so I do a lot of work with IEEE, the Institute for Electrical and Electronic Engineers, and I lead a global working group on clinical Internet of Things, data and device interoperability with TIPS, which stands for Trust, Identity, Privacy, Protection, Safety, and Security. And we look at, the use of AML, we call him, like we gave him a name, AI/ML, Artificial Intelligence and Machine Learning. And we actually have some standards coming out from the Engineering and Medicine Biology Society regarding the quality of data sets and how you use AI and ML and in an AI and ML environment. So they're trying to get into it. Very honestly, they weren't talking enough about bias, so we gave them a lot of input to go deeper, peel that onion and explain what bias really means. And it's interesting because IEEE is very international, and there are some people working on this standard who live in a rather homogeneous environment where people mostly look the same, and they don't worry so much about some of the things we worry about here in the US. And so it's a very different discussion for them. How you would use artificial intelligence and machine learning, what data you choose to use, and how you would use it from a bias perspective. And so it really brought out the differences based on region, based on your environment, based on how you think. And we're trying to kind of normalize it so that depending on the culture and the policy and the regulation in your region, it could apply. It's going to be, it depends, but that you have to think about it. So I think it's growing in interest with the engineers and the scientists who want to be able to use AI and ML for their devices, data sets, and systems. And so I would encourage each of us to push the discussion like you all are here. This is very healthy. It's a very healthy discussion. Push it so that we actually think about what it means, and they can mean different things and have different implications in different environments. Great. How can we follow the progress from your working group? Oh, Giannis, it's really fun. You can send me an email, or you can just go to, if you Google IEEE P2933, we talk like a bunch of robots, beep, beep, P2933, but it's project number 2933. And it's actually the first working group that's developing a standard together between IEEE and Underwriters Laboratories, because I want to have a conformity assessment option in the future where people are conforming to this TIPS framework: trust, identity, privacy, protection, safety, and security. We also have a couple of books on it. You can go to, let's see, / this is my personal website. If you go to fdhint.com and look under writing, you can see it's in the Women in Engineering and Science series at Springer. So pardon that women is in the title, but it's Women Securing the Future with Tips for IoT. And I have people from GlaxoSmithKline and CERN and the city of San Francisco, a bunch of people in that book. And we have a new one coming out, hopefully later this year. It's in production on connected healthcare, Women Securing the Future with Tips for Connected Healthcare, this whole trust, identity, privacy, protection, safety, and security space. So we're going as deep into it as we can. We're trying to increase awareness of the challenges. And then we're creating, standards to address them. So everyone is welcome. The IEEE working group is open. If you're an IEEE person, it's either individual or entity-based. It's individual, so you don't have to pay anything. You can join the working group and you can come along on the ride. We have about 240 people in it right now. We have like 30 to 60 that come to any of the monthly working group meetings. So you're all welcome to participate. The more brains, the better. And what we're hoping is that when we get the first version of this standard out, hopefully the beginning of next year, we're hoping and praying on that it will actually attract more people who can help us bring it to even a deeper level. Because this is a longitudinal challenge as we have more technology, and then we go to, extended reality and AR and VR and, different things you can do in a chip and in a device. It's going to be an ongoing problem: trust, identity, privacy, protection, safety, and security. And then the regulation that's changing. So you're all welcome to join. And then
Florence, since you're talking about standards, are you working together with NIST, National Institute of Standards? So it's a part of your IEEE and NIST collaboration. Can you put some references on NIST site in the chat?
Yeah, so there are a number of them. The NIST CCOE, the NIST Cybersecurity Center of Excellence, has a number of things. They actually had a call for input on clinical IoT and security last year, I think it was. They've had some other ones this year. So there are a number of them. I don't have them memorized, to be honest with you. But if you look at NIST, I'm sure you can find the security and privacy ones. We do have somebody from NIST, I think, in the working group. We have NIH in the working group. We have the FDA present to us at least once a year. So we are connected to all them. And of course, have you all heard of I Am the Cavalry? No, I Am the Cavalry. So that's an organization where they talk about do no harm with medical devices. So kind of like, the Hippocratic Oath. for medical devices. They got up at a DEF CON meeting. I'm a cybersecurity person too. I used to work for the NSF Cybersecurity Center of Excellence. And one of the guys got up at DEF CON, which is a hackers conference, but you have to know the bad guys to see what they're going to do, and said, the cavalry is not coming. We are the cavalry. If we're going to make sure that we have security, privacy, safety, and protection of these devices, that's on us, because if it was happening, we would know. So we actually have a lot of people working on this. So IamTheCavalry.org actually has been growing quite a bit. And we're trying to make sure that we have all this, tips, privacy, and security stuff. So very good questions, but NIST has a bunch of stuff and they're always coming out with things. They're a moving target in a good way. But the NIST Cybersecurity Center of Excellence actually does some work in this area. They're CCOE. Good question. Well, as always, we're so delighted that we have all these brilliant people who come to these calls and we can have these very deep and powerful discussions. Anything else before we let you go 5 minutes early?
You can add the reference to IamTheCavalry.
Yeah, I am the
Probably misspelled
cavalry.
it. Yeah.
Yeah, I think it's I am the cat. Let me just look it up to make sure they didn't move. I am the cavalry.org. Yep, let me get it for you. Let me stick it in here.
The .org, obviously.
Yeah, it's a .org. Yeah, it's not for profit. Very interesting. It's a grassroots organization. Yep, it started at DEF CON a number of years ago. And it started with medical because we're honestly, as a cybersecurity person, I created the IoT strategy at IBM years ago when I was an executive there before I retired the first time. I keep flunking retirement. And we were looking at all the challenges of end-to-end trust and security. And this, came up that we should look at the medical side first, because if they hack a medical device, they can immediately kill somebody. The next step is transportation, because that could be rather quick too. And then we're looking at the other ones too. They have connected home and infrastructure. So what I've been looking at more as compared to CIA, confidentiality and the security pyramid, I'm looking more, what about when it touches the humans? Because technology has been consumerized. We have it in our bodies, in our hands, in our baby, everywhere. So we really have to worry about protection and safety and keeping the humans alive. So that's the transition we've made. And that's what we're trying to do, is get a better handle on how to help with that today and into the future. So any standards we create today, what we talk about is that it has to be extensible into the future. We don't know what we don't know about the future, but we have to think of it that way, that when it goes into XR, AR, and VR, what is that going to mean? What about this? So that's what we're trying to think about. We can't foresee the future, but we can think about how it can be extensible. And that's what we're trying to do as well. So thank you for all those great questions. Anything else?
Thank you, everyone. It's been a great webinar, a great conversation. And we hope you'll join us for our future events when we finish our roster for 2022 events in the next couple of months.
Thank you, everybody. We hope to see you again soon. Be well, stay safe.
Thank you very much.
Thank you.
Thank you, Lauren.
Thank you, bye.
Thank you. Thank you, Lauren. Bye-bye.
Bye-bye.